This lecture is on weakness, syncope, and sudden death. We'll start with episodic weakness, which can really be difficult to try to find the correct answer. There are a lot of differential diagnoses for episodic weakness, including both cardiac and non-cardiac causes. Non-cardiac causes can include muscular diseases, orthopedic problems, neurologic diseases, metabolic disorders, hypovolemia, for example, in older dogs due to internal blood loss from a mass, or thromboembolic disease. Specific cardiac causes, which I'm indicating are reduced cardiac output, may occur due to either a bradycardia or a tachycardia, or obstructive lesions such as pulmonic stenosis, subaortic stenosis, or hypertrophic obstructive cardiomyopathy. Animals with poor contractile function and low cardiac output may experience episodic weakness, as can animals with pericardial disease and cardiac tamponade. Several key historical details may be useful in trying to determine the cause of episodic weakness. Is it just the back legs, or are all four limbs affected? Do the owners notice altered consciousness? What's the duration of the episode of weakness? What's the recurrence, or how frequent is it happening? Is it related to exercise or not, as an exercise-related event might contribute to interest in a cardiac cause? How quickly does it come on? Does the animal have concurrent metabolic or systemic disease? Or is there shortness of breath as part of the disease process? This cat coming down the hallway is going to experience an episode of weakness and or near syncope. It sort of goes down, kind of stretches like it looks like not much is happening, but it eventually then would get up. Physical exam findings are key in animals with episodic weakness. You pay particular attention to the neurologic system, orthopedic exam, cardiac system, and respiratory system. The physical exam findings may help direct appropriate diagnostic testing, but that might include a complete blood count, biochemistry profile, urinalysis, thoracic radiographs, radiographs of a limb or spine, MRI or CT, possibly CT with angiography. For cardiac disorders, blood pressure, ECG, and echo may be helpful. And if a cause is not identified on initial testing, then abdominal ultrasound or abdominocentesis if the fluid is in the abdomen is appropriate. We transition now to syncope, which can be defined as a sudden transient loss of consciousness with spontaneous recovery. Syncope can be a precursor to sudden death, or it can be a relatively benign event. And some people use the term pre-syncope, where an animal has an event, an episodic weakness, but does not lose consciousness. So again, that's similar to what we just talked about with episodic weakness. Syncope is common in dogs with cardiac disease and also with certain systemic diseases, including anemia or problems with blood pressure control. Syncope is less common in cats, and it is even less common in horses. We'll look at a couple of animals here that had events that were judged to likely be due to syncope. The first is a cat here who's going to have an event, fall over, do just a little bit of twitching, but not really tonic-clonic activity, and it's back up and ready to be interested in its environment very quickly. That's typical of syncope. We'll look now at a big dog on the lower left panel who's going to experience syncope. See it go down, and again, not much twitching, not much other activity in that particular case. We'll contrast that to another dog here, a bulldog that has an episode. It's hard to tell in this one, is this syncope or is this a neurologic event? There's twitching that might be associated with a neurologic event, but the dog recovers quite quickly and is ready to be very interested in the environment very quickly after the event. Its color is nice and pink. And finally, in the upper left panel, we have a cat. And this cat, who had been resting comfortably, is going to experience syncope here in a minute. It's going to recognize that the event is starting to come on. There, it can feel it coming on, and then the cat's going to go over with its syncopal event. So these events can be very scary. It's sometimes not clear whether an animal is going to get up from a syncopal event or not. Our gray cat is getting up and a little disoriented, not quite sure what's happened. But that's relatively typical of a syncopal event of cardiac episode as opposed to a seizure. Syncope is a clinical event. It's not a specific diagnosis, since there are a number of things that can cause syncope. And the cause of syncope should be sought aggressively, in part because some animals have a single episode of syncope before sudden death. In contrast, there are other animals that either have only one episode of syncope and then never have another event, or they can have repeated episodes of syncope with no progression to a crisis event. One study tried to look at potential causes and diagnostic tests associated with collapse or syncope in dogs. And again, this kind of points out that some dogs will resolve after an event without any intervention, that it can be difficult to confirm a specific diagnosis, although the cause for syncope can be the cause of death in a significant proportion of cases. And many of the dogs eventually succumbed to the disease that was causing the collapse. So this is part of the frustration with syncope, in that it can be hard to find a diagnosis, and the urgency associated with syncope, in that in many times syncopal event is a precursor to something bad to happen in the near future. Potential causes of syncope or episodes of collapse can include hypoglycemia, which sometimes results in a collapse episode and sometimes leads to seizure, hypoxemia, mild to severe anemia, hyperviscosity syndrome, and hypotension that can happen as a result of hypovolemia, such as blood loss, or hypotension due to inadequate vascular tone, as might be seen with certain vasodilating drugs, or finally hypotension and low cardiac output as a result of cardiovascular causes. So let's probe at those cardiovascular causes a little bit. Bradycardia can lead to collapse or syncope. Often in dogs and cats, it takes a period of bradycardia of at least 9, 10, or 12 seconds before animals will lose consciousness. Tachycardias can lead to syncope, such as ventricular tachycardia or supraventricular tachycardia. Animals with either myocardial failure or obstructive lesions, such as pulmonic stenosis or subaortic stenosis, can develop low cardiac output, especially on exercise, excitement, or exertion, and this can lead to syncope. Animals who have restriction to cardiac filling as a result of either cardiac tamponade or tension pneumothorax can also have collapse or syncopal episodes. One of the potential causes of syncope is sometimes termed vasovagal syncope or neurocardiogenic syncope, and this is due to an abnormality in vascular tone and an excessive reduction in either heart rate or blood pressure, or both, in response to certain stimuli. Finally, certain dogs with cardiac or respiratory disease can experience cough or tussive syncope, where as a result of a paroxysm of coughing, there is a reduction in blood flow to the brain and they can lose consciousness. Let's talk a little bit more about neurocardiogenic or vasovagal syncope. This is a very common cause for syncope in people, and it occurs in dogs, but it's a little bit more difficult to prove. It's almost a diagnosis of exclusion in that you need to rule out other causes such as arrhythmia or obstructive causes or other systemic disease. And it's very difficult to confirm that this is indeed the cause of syncope. Neurocardiogenic or vasovagal syncope results as a result of either baroreceptors or cardiac mechanoreceptors sensing overstimulation, and the messages from efferent neurons going to the brain are there's too much cardiovascular tone and cardiovascular stress. As a result, the CNS output is less sympathetic tone, increased parasympathetic tone, and the result is a drop in heart rate, which leads to low cardiac output, as well as a loss of vasomotor tone, which leads to hypotension. So the cardiac effect can be a combination of both bradycardia and plummeting blood pressure, which leads to a reduced perfusion of the central nervous system, and that's the cause of syncope. Triggers for vasovagal syncope in dogs can include anemia, hypovolemia, congestive heart failure, or being a predisposed breed such as a boxer. And in people, other emotional stimuli and or inadequate sleep or alcohol can also trigger vasovagal syncope. Differential diagnoses for syncope can include seizure, narcolepsy, catalepsy, or collapse from muscular or orthopedic diseases. One of the most important things to try to differentiate syncope versus seizure are the historical findings that you get from the owner. And they can be very similar. For both syncope and seizure, often the owner reports that there's been a seizure. It's hard for owners to identify that this is a cardiac collapse as opposed to a seizure. Both of them have loss of consciousness. In both syncope and seizure, the animal collapses and is often on its side. Urination or defecation is more often seen with seizure, but it can happen with syncope. And the head and neck may extend back with both of them, or in syncope, sometimes the head and neck and limbs are flaccid. Syncope can be precipitated by exercise or cough, whereas seizure usually has no relationship to activity. With syncope, there's often no or only a very brief preictal period, where seizure, there's a little more frequently a preictal period where the animal might wander around a little bit because they feel it coming on. Syncopal events are often shorter duration, often less than 30 seconds in duration, whereas seizure events, the ictus is often 1 or 2 minutes or sometimes longer in duration. With syncope, the limbs are often flaccid, although sometimes extended, whereas with seizure, there's often classic tonic-clonic limb motion during the ictus. Sometimes animals with syncope will have some limb motion or something that looks like paddling when they try to recover. The recovery from syncope is often fast, 30 seconds and 2 minutes, until they're pretty close back to normal, although that's not always true in large breed dogs who have underlying cardiac disease, where a postictal phase is often seen with a seizure that lasts minutes to hours. With syncopal events, classically there's no hypersalivation or facial chomping, whereas in animals with seizure there is often hypersalivation or facial chomping associated with the event. Diagnostics for syncope, as we just identified, history is very important, and the physical exam is normal in many animals that have syncope, although you may identify physical exam findings such as arrhythmia, gallop, murmur, or signs of heart failure that trigger you to a cardiac cause. Mucous membranes may be pale, especially in animals with anemia. There may be abdominal distension if there's either right heart failure and or a mass in the abdomen. And classically, animals with syncopal events have no overt neurologic deficits. The ECG can be helpful for certain arrhythmias, but the ECG will sometimes miss transient arrhythmias. The echo is very helpful to identify underlying cardiac disease. Thoracic radiographs may be useful even if there's no overt cardiac or pulmonary signs. And a complete blood count, biochemistry profile, and urinalysis is generally recommended for the workup of animals that have had a collapsing episode. In animals with shortness of breath, arterial blood gas or pulse oximetry may be helpful. And if the prior testing failed to identify a particular cause or a direction to head focus diagnostics, then event monitor recording, Holter monitor recording, or ECG recording in the hospital may be helpful. Blood pressure may be useful to identify either significant hypotension or sometimes hypertension in older animals. And if no other cause is identified, then abdominal ultrasound should be performed. This is an example of many animals with cardiac arrhythmias who have continuous ECG monitoring in an ICU environment. There is no report generated from this. There's no quantification of arrhythmia unless a technician makes some notation in the record. We're just watching the electrocardiogram for abnormalities. So this is different than a Holter monitor recording or event monitor recording. Holter monitor recording is a 24-hour continuous ambulatory ECG recording. It records typically 2 or more ECG channels for 24 to 48 hours. And when the report comes back, it gives an accurate count of the number of QRS complexes in 24 hours, the number of ventricular premature depolarizations in 24 hours, the frequency and length of repetitive ventricular or supraventricular arrhythmias, a minimum heart rate, maximum heart rate, the length of pauses in heart rate, and a number of other features. Holter monitor recording is relatively useful in animals with arrhythmia as a potential cause for syncope, And the more frequent the syncope is, the more likely a Holter recording for 24 or 48 hours might capture an event. In some animals, even if they do not collapse while they're wearing the Holter recorder, it can be suggestive of an arrhythmia that might be associated with syncope, even if syncope doesn't happen during the recording. This is an example of an older Holter monitor recording where leads are placed on the chest. A recording is obtained. Many of them are now digital, and the device is wrapped around the chest. And often the animal goes home with an Elizabethan collar to prevent them from disturbing the ECG or the Holter monitor or the wires. Then when they come back, are reports generated. As you can identify, there are a number of things from this report. It gives the total number of QRS complexes, the number of ventricular and supraventricular beats, the relative frequency of ventricular arrhythmias and the runs of ventricular tachycardia, as well as minimum and maximum heart rates. Another option is an event recorder, which is a continuous loop recording. The one in the upper right saves 30 seconds to 3 minutes of ECG, and it has the ability to have the owner depress a button at the time of a collapsing episode. The lower right identifies one of the implantable devices that's also available. This can be implanted and the ECG can be monitored over a sustained period of time. And some studies have suggested a better diagnostic yield from event recorders than Holter recorders. Management of syncope is largely dependent on the underlying cause. Animals with high-grade AV block or sinus arrest due to sick sinus syndrome are best treated with a pacemaker, although drug therapy may be helpful. Tachycardias are typically treated with antiarrhythmic drugs. Heart failure and baroreceptor dysfunction, which is common in small breed dogs with myxomatous mitral valve disease and heart failure, may be improved with digoxin treatment of heart failure or potentially theophylline. Tussive or cough syncope may respond to cough suppressants, and vasovagal syncope can be difficult to try to treat, although some people have proposed that either beta blockers or digoxin or theophylline may be helpful to reduce the frequency of syncope. And if there's no specific cause identified, then in many instances we would not start a therapy empirically. If it's a bradycardia and you give a therapy to try to speed the heart rate, that might be inappropriate if the animal's collapsing from some sort of tachyarrhythmia. And similarly, if they have a tachyarrhythmia and you try to suppress that, but they're really collapsing from a bradycardia, you haven't probably done them any good. So usually trying to find the cause is really important if you're going to direct therapy in the correct direction. Sudden death or sudden cardiac death has a couple of different definitions. One of the definitions is defined as an unexpected death of cardiac cause generally occurring within 1 hour of onset of signs. That's probably the definition that is most commonly used in people. A definition in veterinary medicine is usually within a 12 to 24 hour period of time, an unexpected death due to a cardiac cause. So there are a variety of causes of sudden death, including cardiac causes such as arrhythmias, cardiomyopathy, cardiac tamponade due to pericardial hemorrhage, or thromboembolism or pulmonary hemorrhage, or CNS events such as stroke, aortic rupture or an anomalous coronary artery, and has been reported in horses as potential causes of sudden death. And sometimes animals are just found dead at home, which might be a cardiac cause, might be sudden cardiac death, or it might be a result of gastric dilatation and volvulus or a splenic mass. Rarely is it a toxin. Two examples here of animals that arrested The first one had ventricular tachycardia that degenerates into ventricular fibrillation. And the other was having a bradyarrhythmia that then resulted in ventricular fibrillation. There's a study that looked at what cardiac rhythm was diagnosed at the time of cardiopulmonary arrest for hospitalized cases. And it can include ventricular fibrillation, sinus rhythms, in which case then probably the arrhythmia was not the cause of arrest, pulseless electrical activity, which used to be called electromechanical dissociation, asystole, ventricular asystole, and less commonly ventricular tachycardia, atrial fibrillation, or AV block for hospitalized cases. Arrhythmias that are recognized to be associated with sudden death in animals include asystole, pulseless electrical activity, advanced AV block, ventricular fibrillation. And supraventricular tachycardia probably is only associated with syncope. Here's an example of an animal that had a serious ventricular arrhythmia and then experienced asystole. And asystole would usually be managed by initiation of cardiopulmonary resuscitation and administration of epinephrine. Pulseless electrical activity, which used to be called electromechanical dissociation, is identified by the presence of an electrical rhythm on the electrocardiogram, but no pulses and often no cardiac sounds. This can be due to severely depressed myocardial function or inadequate blood volume returning to the heart, as might be seen with cardiac tamponade at the time of arrest or tension pneumothorax, or pooling of blood away from the cardiovascular system. Advanced AV block can also be a cause of collapse or cardiac arrest. And because advanced AV block can be associated with sudden death, the preferred treatment is cardiac pacing. Cardiac pacing will significantly reduce the chance of sudden cardiac death, whereas the drug therapies that have been used will usually not prevent sudden cardiac death. An atropine response test may be useful. Here, this animal, which had a bradycardia at the beginning with some AV block, had an increase in the sinus node firing rate and an increase in overall heart rate, but there's still significant AV block. So perhaps a partial response to atropine in that dog. Ventricular arrhythmias certainly can be associated with the development of either fainting or ventricular fibrillation causing sudden cardiac death. In animals with systemic disease, you might do a little bit of workup to try to identify whether there's underlying cardiac disease or not. And in animals that are presumed to have systemic disease, such as gastric dilatation of volvulus or splenic mass or hit by car, there are a number of other factors you might think about relative to management of the arrhythmia. Lidocaine is the mainstay of initial management of ventricular arrhythmias in dogs and cats. And for long-term therapy, drugs such as sotalol, mexiletine, amiodarone, possibly in combination with beta blockers, have been used to try to prevent sudden death due to serious ventricular arrhythmias. The efficacy of these drugs are unknown, and the bigger studies in people have shown that some of the commonly used antiarrhythmic drugs may not be all that effective in trying to prevent sudden cardiac death, including class 1 drugs, which had a worse outcome than placebo, and sotalol, which may have been similar to placebo, depending on the study you look at. The main thing that improves outcome in people who are at risk of sudden death is an implantable cardioverter defibrillator, and that would be the therapy of choice, although in most of the dogs who are reported to have had an implanted cardioverter defibrillator, they continued to have events of being shocked at inappropriate times due to difficulty with programming the implantable cardioverter defibrillator. Ventricular fibrillation, when identified, is an emergency. There is no cardiac output that occurs when ventricular fibrillation is happening. Animals lose consciousness within 5 to 20 seconds of the onset of ventricular fibrillation, and without resuscitation or conversion back to a pulse-generating rhythm, they're going to die. So defibrillation is the main way to try to address ventricular fibrillation, or we could do cardioversion for atrial fibrillation, typically by electroshock, also called DC countershock. And for ventricular fibrillation, the time from the onset of ventricular fibrillation until the point of time of defibrillation is the most important factor in human survival of cardiac arrest. This points that out that if defibrillation occurs in the first 2 minutes of ventricular fibrillation, you've got a pretty good chance, whereas once you get out to 8 or 10 minutes after the onset of ventricular fibrillation, the chance of resuscitation, even with the defibrillator, drops rapidly. This is part of the reason for the development of defibrillators that are readily available in sports arenas, on airplanes, in police cars, etc., to try to get people who have collapsed due to ventricular fibrillation defibrillated as soon as possible. So defibrillation with a defibrillator is really the way to go. The electrical current must traverse the heart, with many of the cells being depolarized by that electrical shock. One study suggests at least 28% of the cells need to get depolarized. And hopefully the new rhythm is a pulse-generating rhythm. If ventricular fibrillation persists, then you may give repeated shocks, 2 or 3 in a row, before escalating the energy. And you would continue cardiopulmonary resuscitation with epinephrine, perhaps amiodarone or magnesium. Indications for defibrillation include ventricular fibrillation, ventricular flood or torsade de pointe, or pulseless ventricular tachycardia with loss of consciousness. Most people do not recommend defibrillation for asystole or pulseless electrical activity. The energy varies based on the size of the animal, and we show here what it looks like for ECG synchronized cardioversion. This is in a bulldog that had serious arrhythmia, and you can see the legs jumped up as the time of doing the conversion, and that there's now a normal rhythm there. We'll watch that one more time. Take a look at the back legs. The front legs are taped down to prevent the animal from moving. You can see there's quite a bit of a jolt given during defibrillation. If the chest is open, you can also do intrathoracic defibrillation with lower energy requirements, so lower energy selection. Saline is put on the paddles, and you use the paddles to squeeze the heart between the paddles and then deliver the shock. And it's been proposed that the coarser the waveform, the easier it is to defibrillate, that higher frequency waveforms that are coarser are easier to defibrillate than lower frequency. And this is part of the recommendation that causes people to give epinephrine or vasopressin, which might coarsen or increase the frequency of the waveforms before defibrillation. Still, if you've identified ventricular fibrillation, you should defibrillate first and then give additional drugs and continue with CPR and then repeat defibrillation. So thank you very much for listening, and we hope we don't have to defibrillate any peeps.